You should hear that now that the recording is going to be operating. Good. Okay, excellent. So thank you again for joining and taking time in your day to come to this Thursday topic, or the 411 on the 911, sedation and awakening. Now, this is really applicable to any patients that we see who are in critical care, and most particularly talking about patients who we have intubated and placed on mechanical ventilation. Now, we all know that the idea of comfort, despite the fact of how we would like to see it applied, that the idea of intensive care comfort is about alleviation of anxiety, not necessarily about creating sedation so patients are literally semi or unconscious. That really is not the goal. The goal of the application of pain management and anti-anxiety and sedation protocols is to actually reduce anxiety of the patient. And of course, in order to do that, the very first thing we have to do is relieve pain. So that's going to be a very significant component. And what we talk about when we're thinking of our mechanically ventilated patients is, number one, assume pain. Treat pain first. Always assume pain and treat it first. And then to just remind ourselves that despite the fact that we might have patients who are on propofol or midazolam or lorazepam, we walk into the room and the patient's eyes are closed and we can't really stimulate them very much, and we say, oh, they're sleeping. We say to the family, he's sleeping. But actually, we know, and we've known for about 18 years, that aggressive sedation methodology deprives patients from REM sleep. And one of the most important components of REM sleep is that there is restoration of cerebral proteins during that REM sleep. So really important for us to remember that when we talk about how we're managing a patient who is anxious and thrashing. And of course, we want to protect them from themselves and protect them from the incredible fear-inducing prospect of intubation and physical restraints. But we also have to remind ourselves, the more we sedate our patient, the more likely it is that they're going to develop delirium. So we really want to be aware of that when we're talking about sedation and analgesia in patients who are intubated. Now, all of us know that we need for patients to cooperate with ventilation. So they're intubated, they're on mechanical ventilation, and they're dysynchronous. And they're, if you're looking at a graph on the ventilator, you see that the ventilator initiates the breath and then they try to take a breath on top. It's called double humping, and it's profound dysynchronicity with ventilation. And oftentimes what I find is, if I call the therapist and say, look, I'm really concerned about what's happening with my patient, they often will say to me, much less often now, but in the past, your patient's not sedated enough. But quite honestly, it's really important to remember that ways to facilitate ventilation are to adapt the ventilator to the patient. So you have to change that framework in your mind. Rather than trying to make your patient fit the ventilator, you need to change your ventilation to fit the patient. Sometimes the flow of gas is so slow that patients can't really endure it. They feel like they're suffocating. They feel like they're being waterboarded or buried under 6 feet of dirt. And they often describe this when talking about mechanical ventilation. So really important to look at the ventilatory strategy, and is there something that you and your respiratory therapist can work out to actually make ventilation fit the patient more appropriately. Most of the newer ventilators have a pressure limited volume control or pressure regulated volume control. On the current 840 and 940 Puritan Bennett's, that is actually called VC plus. So what that means is that the flow of gas, how fast the gas goes into the patient, changes based on the patient's lung compliance. So the patient doesn't feel like he's trying to pull a breath, but he actually is communicating with the ventilator, and the strategy of the ventilator is to change the flow rate. Now, if you're lucky enough to be working with Hamilton ventilators or servo ventilators, these are really smart ventilators that have a lot of adaptability to the compliance of your patient's lung. And let me assure you that being intubated on a ventilator where we have a pressure control or a volume control can be very fear-inducing for patients. So this actually causes a lot of discomfort and a lot of worry for our patients. Now, the other thing is, obviously, we're taking care of a sick patient. They're on 3 drips, they're intubated, we're doing CRRT, placed a central line, got an A line, lots of things are going on. And our need is for the patient to be calm, for the patient to be comfortable, for the patient to be cooperative. That is not the same as obtunded. So it's really important for us to try to calculate and figure out a strategy that allows patients to be calm and cooperative without them being completely obtunded. Obtundation is not an effective methodology for the majority of your ICU patients. And really important is to modulate the stress response. So now we think about what happens with our patients, that they have a very high degree of sympathetic stimulation. They have a high degree of circulating catecholamines. We're giving catecholamines, and we might be doing that to increase contractility, or we're doing it to increase vascular tone and raise the blood pressure. But the secondary effects of that are tachycardia. And tachycardia is a hallmark sign of significant physiologic stress, of hyperanxiety and hypervigilance. And that actually puts your patients at significant risk. Now, what you can also see, although we don't generally see that with patients who have a high degree of stress response, is that they may have hypertension. For the majority of us, we're praying that the patient's own catecholamines will raise their blood pressure, which is not that frequent and doesn't always work that well. But what I want to really focus on, because I think one of the things we have to consider is that when we talk about sedation, what we really mean is anti-anxiety, okay? And when we think about what causes anti-anxiety, there's a lot of things that cause it. But you can see certainly down here, you have an environment that's light all the time. It never changes. It's very disorienting, even though you might say to your patient every hour, you're at Grady Hospital in the ICU, I'm your nurse Barbara, everything's okay. And we're saying it over and over and over again, but the patient doesn't have the capability to integrate that information and to retain it, and most importantly, to process it. They're not processing because they are overcome in these situations with pain and fear. Frequently, after 2 to 3 days in an ICU, they're suffering from significant sleep deprivation. They have a lot of surgical stress. There's a lot of weird noises. It's daylight most of the time. It never really gets dark. It's never really quiet because there's always alarms going off. Providers are yelling to each other down the hall. Hey, guy in 13, he's coding, come on. And, they're hearing all this hustle and bustle. They have no idea what that is. They cannot process it. If you explain it, wonderful, but they can't process it. And then, of course, we have just providers who are just like, stop thrashing around or I'm going to tie you down. Like you're having a conversation with a 24-year-old college student. That's not who you're conversing with. And this is a critically ill patient who doesn't have the capability to reason. They're not misbehaving. They're not trying your patience. They're not trying to cause you an issue. They are not able to process what's occurring. And this is all related to the environment, to the lack of sleep, to the continuation of pain, to being very confused about where they are, hearing bits and pieces of conversation, or, you've got Law and Order SVU on the TV, and they're hearing these bits and pieces from that and integrating that into their consciousness, and are completely and extraordinarily confused. I think one of the most important passionate methodologies that we as providers can institute in our care is the appreciation that our patients are not operating at their cognitive level, that they are really unable to appreciate and understand what's being said to them. Sometimes they understand it for 5 seconds, but then they lose that. And they have this continuous ongoing amnesia, which is really significant. So all of this causes very significant anxiety. And that anxiety can lead, particularly with sleep deprivation, that anxiety can lead to delirium. Now, just imagine you in a relatively nice position in your life. You have a home, or you have a nice apartment, you have a family, you have food, you're in control of your environment, you're relatively in control of your work. And all of a sudden, you are tied down, you are intubated, you're being turned, you're being prone, you're being washed by people you don't know. People are touching your genitals. You have no idea who they are. You can appreciate that this is a significant change in how a human being lives. And it creates such profound anxiety. And if we just correlated that to being a prisoner of war who wasn't allowed to sleep and who was being waterboarded or tied to a chair for 3 or 4 days, you would eventually slip into a loss of understanding of what's occurring because you've lost sleep. You don't know what to do. You really don't understand what's happening. You can't integrate everything that's happening around you because you have a failure to process. That's what delirium is. And then delirium, of course, can lead to psychosis, which is significant enactment of hallucinations and complete and utter misinterpretation of the signals around us. So we really always want to remember about these 3 perspectives. We call it the PAD criteria: pain, agitation, and delirium. It's the ICU triad. And just reminding ourselves that pain leads to agitation, leads to delirium. Agitation can be caused by pain, which leads to delirium. And we have all this integrating, competing processes for our patients. And just simple things like suctioning and turning and cleaning their genitals and placing catheters. These we see as simple things that we do in our daily practice. But this is really bizarre for the individual who is receiving that care. Now, we have to give that care, and how wonderful it is that we give that care. But I think one of the most important things is to remember that these 3 issues are significantly, profoundly interrelated. And that we absolutely want to control your pain. We absolutely want to control your anxiety, but that most of the medications that we use to control pain and anxiety actually put patients at further risk for delirium. And unfortunately for most patients, I would be quite honest, is to say that 80% of patients who are suffering from delirium in an ICU at day 3, 4, 5 after intubation and ventilation, almost everyone at 2 weeks is going to be suffering from a level of delirium. 80% of them are called hypoactive delirium. So they seem very calm. They're laying very calmly. They're not struggling. They're not combating. They're not trying to extubate themselves, but they're doing that from acute and profound fear. They're trying to make sure they please their captors, that they don't do anything that's going to cause any other problem for them. That's what they see. That's not what we're doing. We know that. We know that we're working with the best of intention, but the perspective of our patients is very, very different. So really important for us to just remind ourselves that we're always walking a fine line between pain and no pain, a fine line between anxiety and no anxiety. And we don't want to go under or over if we can help it. We don't want to over sedate or under sedate. We don't want to over analgize or under analgize. We always want to walk that fine line between overuse and underuse in order to create comfort, in order to reduce anxiety, but not to obtund the patient and create a scenario where we think they're calm and quiet, but they are actually hallucinating and fearful and afraid. So I think all of us know those basic definitions. Just to remember that pain is the perception and the emotional experience that is attached to an unpleasant sensory experience. It could be real or it could be perceived. It could be tissue damage. It could be many things. It doesn't actually even have to be real. It can just be perceived. Potential pain, actual pain, perceived pain. Sedation in our terminology is the stage of quiet and calm. Now, let's be sure we appreciate that. A stage of quiet or calm. That we're not saying obtund them, don't anesthetize patients. We're so frequently jumping into anesthesia levels of propofol and fentanyl, but really all we're actually trying to do is to reduce the pain, not completely obliterate it, but to reduce the pain and to reduce the anxiety. Now, from sedation also comes the terminology of agitation, which means that patients have very significant motor and psychological activities. So again, the patient that you're perceiving, oh, he's really trying my patience. He's all over the bed. He keeps trying to extubate. He keeps trying to pull out his tubes and his Foley. I keep telling him not to do it. Told him I was going to have to tie his hands down, but he just kept doing. I had to tie his hands down. As soon as you tie their hands down, everything significantly worsens. That's a profound worsening experience. Not saying that you're not going to do it, but one of the beautiful things that has changed is instead of just restraining patients, putting their hands in mitts so they can't quite as easily extubate themselves or decannulate themselves. And then that end process, when we have failure to control pain, failure to reduce anxiety, to create a quiet and calm cooperative patient, then there is that process, even when we're doing the very best we can, the process of delirium. I want to make sure we all appreciate delirium. So I'm going to give you basic Barbara's definition. Barbara's definition of delirium is the failure to process what is happening. That it is actual true cerebral dysfunction. The patient can't pay attention, they can't process, and their thoughts are very disorganized. And by the way, we cannot measure whether a patient's delirium by asking them if they know where they are. Do they know what year it is? You know, after they've heard that 3 or 4 times, they've memorized it. And by the way, remember, many patients are, if I say the right thing, they won't hurt me. If I say the right thing, they won't bring all those people in to look at my genitals. That's their perception. So it's really important to remember that why we test patients' ability to have organized thought, to actually remember what we've said, or to be able to take a concept and make it live, like a rolling stone gathers no moss. That might not be meaningful in your population of patients, but you have to find something that is, do you use a hammer to hit a nail? Does a rock float on the water? I mean, things that individuals can understand that test their cerebral connectivity and their ability to have organized thought. This is such an incredibly important point. So we have a lot of tools for evaluation. We look at the pain score, and for most of us in critical care, we use critical care pain observation tool. That's called CPOT. That's what we use here at Grady in the ICU. The behavioral pain score is something that you can use on a step down floor, on a tele floor, where patients can communicate more effectively with you. But critical care pain observation is typically what folks use when patients are critically ill. And in today's world, I think none of us use the SAS. We all use the Richmond Agitation Severity Scale, the RAS, for evaluating whether or not patients are profoundly anxious. And remember, our goal isn't to uptime the patient, just to reduce their anxiety. From that, we have a couple of different methods that we can use to assess delirium, but our primary methodology is the CAM-ICU method. Now, the intensive care delirium screening tool is a very strong tool. It's not quite as easily applied as the CAMS-ICU, and I'm going to talk about CAMS-ICU because that is the most common tool that is used. So if we look at the BPS and the behavioral pain score, obviously you're observing the behavior of the patient, but not having that much integration with them. You're just really observing what's occurring with the patient. I'm sorry, it's just I'm trying to move my visual column. There we go. Good. All right. So I can't see myself anymore, so I might make terrible faces. Sorry. So behavioral pain score goes from 3 to 12. And in general, you would like to have a patient with a score of less than 5. That usually means that you've controlled their pain. So we talk a lot about the facial expression, and you can use your smiley face for this, right? Face is relaxed, partially tightened because the brow is lowered, fully tightened, the eyelids are closed, the patient's grimacing, they're not moving. And then we move to the limbs, and we say, are the limbs partially bent? Are they fully bent with finger flexion, permanently retracted, or tolerating movement? And then evaluation of compliance with the ventilator, right? So we look at these strategies and assign points to these strategies, add those points together. Remember, we'd like to see you less than 5. Now, most of us are not using the behavioral pain scale. We're using critical care pain observation tool. So again, we're going to use facial expression, body movements, assigning point value, muscle tension and resistance, compliance with the ventilator if the patient's intubated, or vocalization. Are they sighing? Are they moaning? Are they crying out? Are they sobbing? And gathering that data together in this CPOT methodology that tells us if we have controlled patients relatively effectively. And then we move from there to what is the most common form for evaluation of sedation, and a really important one, even in the ER, in the ICU, on the step-down unit, everywhere. If you are using any type of anti-anxiety or sedation methodologies, we always want to control, or not control, we always want to evaluate how well we're doing. So this is us. Well, I hope all of us today, 0, we're alert, we're calm, we're listening, we're interacting, we're understanding. That gives you a 0 point. Points up or points down are going to be significant. So you can see as points go up, so these are positive, +1 to +4, is restless, agitated, more agitated, or combative. So frequently after you've intubated a patient, they're going to be at +3 or +4. They're very agitated. They might be combative. They're rolling, they're rocking, they're moving. And of course, you need to protect the patient from themselves. So your physician will typically, your providers will typically write an order using a RASS scale, and they say, please titrate sedation to a RASS score of -1 to -2, which is typically where we want patients who are on the ventilator. -1 to -2. They're drowsy, but they wake up when you call their name. They'll keep their eyes open for at least 10 seconds, right? They're sleepy, but they wake up, and they wake up with just verbal stimulation, and they can keep their eyes open. Light sedation, which is more commonly our focus in someone who's intubated, means that your patient will open their eyes when you call their name, but they can't maintain eye contact, and they really can't keep their eyes closed for greater than 10 seconds. So that's, it's a subtle difference, but it is a difference. But as we move now to moderate sedation, still actually doing in moderate sedation, only verbal stimulus. So you don't go in the room and say, open your eyes, wake up, and kind of shake their arm or pinch their arm. No. You just do a verbal stimulation, and you start with that evaluation. Are they drowsy? Are they lightly sedated? Are they moderately sedated? Okay, they didn't respond to you. They may have opened their eye, but they're not contacting with you, right? And their eyes go closed again. All right, now you're going to move to physical stimulation. So physical stimulation is going to be applied without verbal. You already did the verbal. Now you're going to do physical stimulation, and that physical stimulation is just stroking, might be a little bit of a pinch, not really causing any pain, but actually giving a stimulation, right? So if they didn't respond to the verbal, either 1, 2, or 3, now you're going to give physical stimulation. They start moving around. Well, they are deeply sedated. If they're moving around and you've stimulated them physically, remember, no words spoken now, only physical stimulus. And then -5 means you can't arouse them. You don't even get a response with physical. And you deepen that physical stimulus because you move from a little soft pinch to a little bit harder pinch to a rub. You might rub a little bit here, but you're also not talking at the same time. You're not doing double stimulus at the same time. Now, your providers typically are going to write, and the best practice is that patients on sedation should be between -1 and -2. Sometimes they need a bit more sedation, but when you get to -4 and -5, that's deeply sedated. That's anesthesia type of sedation. All of us, none of us are approved for anesthesia sedation. We're approved for moderate sedation. So once we get to 4 and 5, we have to have some discussion about how sedated our patient is. Now, my role here today is not to teach everybody how to do a CAM ICU. I'd be very happy to do it. I really think it's straightforward. I wrote the original document at Grady. I've written the protocol at Grady for evaluation of CAM ICU. I brought Wes Ely to Grady to do discussions. You may or may not know is Wes Ely is the founder of ICU Delirium. He is the person who developed and tested the confusion assessment method, the CAM ICU. And basically what we're doing is looking at 3 points, okay? So your patient has had acute onset of mental status change. So he was sedate, now he's woken up, he's on the same level of sedation, but now he's woken up, now he's asleep, now he's combative, now he's asleep, and that's changed throughout the course of your shift, okay? And then number 2 is their ability or inability to pay attention. Number 3 means that you have a RASS score that is more negative than -2 or more positive than +1. That's called an altered level of consciousness. All depends on your RASS score. And number 4, when you do your final evaluation, is you ask a series of yes or no questions. You ask them to observe you holding up fingers, putting your fingers away, and asking them to do the same so that they are actually seeing, they are processing, and they are performing. Seeing, processing, performing, or hearing, processing, and answering. That's the disorganized thinking component. And patients who are delirious may look fine, but when you get to testing their organizational thinking, you discover they are definitely not. Now, remember, I said the very first thing is you're going to get your pain controlled, and then what are you going to do, right? So the guideline recommendations, that's the ABCDEF guidelines from the Society of Critical Care Medicine, also endorsed by the AACN and the ENA, and for CRNA is everywhere. Guideline recommendations: analgesia first, control pain, and then introduce some level of anti-anxiety or sedation. And we're going to maintain very light levels of sedation when it's appropriate. Obviously, if you have a patient who is profoundly combative, they're withdrawing from alcohol, they're withdrawing from benzos, withdrawing from cocaine or methamphetamine, you might need a higher level of sedation, but not forever, just when it's appropriate. And remember, you're going to work really hard to keep patients comfortable, calm, cooperative. Comfortable, calm, cooperative with care. That's your goal, not to obliterate any performance by the patients. So then we think about, after we control pain, now we're going to look at sedation in addition to analgesia. So most of the analgesic agents that we use, the primary one we use, which is fentanyl, has some component of sedation, but it's primarily an analgesic. Sometimes I hear people say, well, the doctor ordered fentanyl for sedation. No, I mean, fentanyl has some sedating properties, but it's an analgesic. That's great. We're using fentanyl to control your pain. And we're going to add in some level of anti-anxiety or sedation to actually keep the patient calm and cooperative so that they will interact with the ventilator. But please remember, the very first thing you always have to do is evaluate whether your ventilatory strategy meets your patient's needs. The thing is that many of our strategies were designed for the days when patients were basically paralyzed. We don't really do that anymore, except in extraordinary circumstance. So we have to change our ventilatory strategy and have the ventilator and the patient have a better interaction. That's why we really want to use smart ventilators. We want to have capability for pressure limited or pressure regulated volume control. And in our ventilator, that's called VC+, that allows the ventilator to behave intelligently in relationship to the patient's flow rates and to their lung compliance. So that's a really beautiful thing. We obviously have to keep patients safe. We have to be able to perform care. We want family members, very important that caregivers and family members feel and perceive that their loved one is comfortable and not fearful. And most importantly, you want to use a balancing agent that actually is going to promote sleep. So it's really important to remember. So sometimes I would say in ICU, we can knock our patients out. We can titrate up on their sedation, add Versed to our propofol, think about aggressive benzodiazepine, going up on our fentanyl, because it's pretty easy to knock your patient out. Now, to do it correctly isn't so easy, but what we want to remind ourselves is that what we want to do is to keep them calm. And that needs to be our underlying strategy. We're trying to keep patients calm. So just taking a look at some older literature, which has been repeated again and again and again, looking at long-term mortality in ventilated critically ill patients who receive early deep sedation. And that is deep sedation. So that means -4 or -5 was a significant predictor of hospital mortality and of 180-day all-cause mortality, and was also significantly impacting how long patients stayed on the ventilator. Now, that's not a big surprise to us. This has been repeated again and again and again, and we all really appreciate and understand that when we don't actually keep those C's together, when we talk about sedation, that the goal is to keep the patient calm, comfortable, cooperative, and communicative, which means to a RASS goal of -1 to -2 and occasionally to -3. But beyond that, unless we have a particular reason, we should never be sedating our patients at any higher level. So we're going to think about a couple of different agents, and you're going to see them listed here as sedation. So you know propofol, which is in its own class, dexmedetomidine, which is in its own class, and midazolam and lorazepam, which are benzodiazepines. So they all can promote some anti-anxiety to sedation effects. So I want to just make sure that we appreciate that if you have liver failure, you will not be able to clear propofol. If you have liver failure, you will not be able to clear dexmedetomidine. If you have liver failure, you will still be able to clear midazolam, which is why midazolam is the drug of choice with individuals who have liver dysfunction. And the same thing here, clearance is hepatic for lorazepam. Now, I want you to notice, this is just the general recommendation that has not changed since really the development of strategies and guidelines, to say that propofol 5 to 100 mics per kg per minute, dexmedetomidine 0.2 to 1.4. And at our hospital, you don't go above 1.0 without a specific order or a specific discussion with the pharmacist, because the higher you go on this agent, the more sedating effects you're going to see with dexmedetomidine. That's Precedex. Okay, for midazolam, the thing that's really important to remember about midazolam and lorazepam is that you have to saturate the receptor sites. So if you're using midazolam or lorazepam, the goal would be bolus, 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 calm, and then increase your drip. Don't increase your drip every time you bolus, because what ends up happening is you're bolusing and bolusing and bolusing and going up on your drip and going up on your drip and going up on your drip at the same time. And now all of a sudden your patient is at RASS -5 because now you've saturated all those receptor sites and you're maintaining a very high level of circulating drug. So most pharmacists will tell you, if you're using midazolam or lorazepam, you do bolus, 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 bolus. Typically, you get up to 10 to 12 milligrams in your bolus, and then you increase your drip. And that can be very helpful just to appreciate and understand. Now, we think about 3 different categories, and I'm going to mention here that what you're going to see in routine sedation, sick patient sedation, recovering patient sedation, you're going to see dexmedetomidine. Now, dexmedetomidine has, I think for many ICU nurses, got kind of a bad rap because you put your patient on Dex and Precedex, and they are not actually obtunded. They just have anti-anxiety. So it's really important to remember that dexmedetomidine is a drug of choice when patients were trying to recover, patients were trying to get them to breathe on their own, because dexmedetomidine, as long as it's less than 1.0, is not going to suppress the patient's respiratory effort. It basically would be an agent that you might take if you had a fear of public speaking and you had to get up in front of 1,000 people and you were vomiting in the bathroom and you were so nervous. Now you're not going to take dexmedetomidine because it's IV, but you might take Anduril or beta blocking agents. So dexmedetomidine is an alpha blocker, but it will reduce the patient's anxiety. So really, really important to remind ourselves that we really want to think about anti-anxiety. Now, when patients are really sick, we're going to sedate them. We're going to give them a sedation. It may be a benzo, it may be propofol, but particularly as you are moving towards awakening and weaning from the ventilator, dexmedetomidine is going to give you so much more bang for your buck. So why don't we like to use benzos? Well, first of all, benzos make patients unable to cooperate. They're associated with respiratory depression. They are profoundly linked to significant forgetfulness or amnesia about events that are occurring, which then propagates misinterpretation and can stay with patients for a year, 2 years, the rest of their life, really creating a post-traumatic syndrome that actually is profoundly limiting for patients resuming their quality of life. It also frequently, of course, requires additional narcotics, but we have to do that with just about everything else. But I want you to look at the risk for transitioning to delirium. So again, we've got things in here that are not just benzos, right? Fentanyl and morphine have some anti-anxiety effect. But what I want you to see here is the use of midazolam transitioning to delirium odds is 1.7. That's pretty darn significant. It means that the majority of those patients' independent risk factor for daily transition to delirium was very high. 20% increase in transition to delirium with the use of midazolam. Doesn't mean it's not a great drug, doesn't mean you should never use it, but you really have to be wise about it. You have to give patients sedation vacation, you have to evaluate them, you have to train them, and you're going to use the least amount required to get to a RASS that's been ordered and not to overshoot to a RASS -4, -5. And then, of course, you see that propofol and morphine and lorazepam have a pretty similar strategy, as well as fentanyl, although, again, I wouldn't necessarily say fentanyl or morphine for anxiety. Now, why is it that we want to use anti-anxiety? Okay, so I'm just going to tell you that I think it has been made as a case again and again and again and again, is that these patients have hyperstimulation. They have a high degree of sympathetic nervous system stimulation. They appear very anxious. They act very anxious. They're tachycardic. They often can have systolic hypertension. They will hyperventilate and combat with the ventilator, and they are struggling. So when we evaluate a patient, we see they're tachycardic, they're tachypnic, they have a high degree of anxiety. We want to think about controlling their hyperadrenergism, which is not a real word. I've just made that up. Hyperadrenergic patient is what we want to control. Now, the use of dexmedetomidine is that it actually improves cerebral blood flow in the area of the brain that controls anxiety. So it decreases that neuronal effect. It decreases the activity of the GABA stimulant, and it reduces the response to the catecholamines that are hyper-released, but most particularly because it improves that hippocampal blood flow. Now, alpha-agonists, and that's what dexmedetomidine is, very important to appreciate. You would not use dexmedetomidine for somebody who has an increased intracranial pressure. It doesn't affect that. You really need propofol. You might actually need Ativan or Versed for those patients. It does not have a synergistic effect on any muscle relaxants that you're using, and it will actually prolong a local anesthetic action. So frequently it'll be used for localized procedures. But a really important thing, because it reduces receptor site activity to alpha stimulation, metabolism is decreased, oxygen consumption is decreased, anxiety is decreased. A couple of things can actually happen with this, and That, of course, is really important. Just like when you talk about opioids, you're going to have decreased bowel motility. You have decreased psychomotor performance. So they're going to be slower on the uptick while that DEX is on board. Their EEG is going to be a little bit slower. But I think one of the things I love to remind us about is that we do now appreciate and understand that there are significant neuro and cardiac protective effects from these agents, which I think is just so phenomenal and really beneficial. So we think about all of this as we consider dexmedetomidine. And I've just given you from kind of early iterations, and that, again, that hasn't changed, is the clinical effects and the adverse effects. And I'm going to just remind you that the biggest adverse effect that we see, that we worry about clinically, is bradycardia. Now, dexmedetomidine is often used when we're doing targeted temperature management. When we make patients cold, they often will drop their heart rates. We've added dexmedetomidine, their heart rate may be 35 to 40. But again, we're going to be concerned about that, of course, because it's an anti-alpha agent, right? It's an alpha agonist. So it's going to reduce their response, right? Their cardiac response, and the heart rate is going to go down. But as long as they have an effective stroke volume and they are stable, that's going to be okay. You're going to be concerned about it when the patient is unstable. And of course you would be, and that makes perfect sense. But I love this. I love this slide. So you can see what benzodiazepines basically do, right? They promote sedation, they alleviate anxiety. Propofol promotes sedation, does not alleviate anxiety. Propofol can facilitate weaning. Opioids, right? They may promote some sedation. That's not why we're using them. And they promote analgesia, don't facilitate weaning, don't help control delirium. But look at alpha-2 agonists. And the only one that we really use, I mean, you could use clonidine, but normally what we're using is dexmedetomidine. You check off every single box here, every single box. So I think overall, the belief is this is an excellent agent for utilization. I think in a lot of hospitals, there hasn't been a great uptick because bedside nurses are not fully understanding what the goal of the alpha agonist is. They're thinking, well, a patient is not sedate and we're having other issues. The idea is you're going to use dexmedetomidine and you're going to increase that dex up to 1.0, but you are also going to use very low level of sedation if necessary. And so some patients are completely calm and cooperative and cool just with dexmedetomidine. Sometimes in the earlier stages where patients have a lot more anxiety, they might need some propofol with dex, and then we wean the propofol off, and then we wean the dex off. And that's a really good strategy. But it is important to see that every single box is ticked. So I just want to remind you, in general, we start actually at 0.1 mics per kg, or we might even start at 0.2, and we increase at 20-minute intervals. And your order should include what the RAS goal is or what the heart rate goal is. And you should have protection so that if your heart rate drops below a certain level, you need to communicate with your physician. You're going to hold your dexmedetomidine for 20 minutes and then restart at half the previous dose. Now at Grady, you can increase beyond 1. The guardrails are 1.4, but you must have a physician order and you should have a discussion with your pharmacist before that happens. So just again, for the back seats, I always want to remind you, you can load a 10-minute loading infusion, 0.4 to 1.0 mics per kg, and typically 0.2 or to 0.7 mics per kg per hour is going to be the most effective. It takes about 10 minutes before you're going to see that effect. So that means you're not increasing dexmedetomidine the way oftentimes you see people increase propofol, right? You have to be very clear that it's going to take about 10 minutes for action. And the action will dissipate in about 30 to 60 minutes. So it's a much slower onset and a slower clearance. You have to know that when you're using dexmedetomidine. And then I just want to talk really quickly about ketamine. Ketamine's been used forever. I had all 4 wisdom teeth pulled when I was 22. and they used ketamine on me. Unfortunately, I think they used a very high dose of ketamine, and I woke up completely hallucinating and delirious. But for most individuals, lower levels of ketamine can actually give a very significant calming effect and significant analgesia. So we just take a look at ketamine and think about the effects that you might see with ketamine. Those are pretty important for us to consider. And again, I want to just talk about how quickly ketamine acts. So I think a lot of you are starting to use a fair amount more ketamine. You're seeing that it's really being implemented. If you work in an ICU where you have critical care anesthetists or anesthesiologists, you use a lot of ketamine. The onset of action is really fast. It lasts about 10 minutes. A clearance is 10 to 15 minutes for the alpha antagonist and 2 to 3 hours for the beta antagonist. So really, really important. Have to have a good liver, have to have a good kidney. So dosing, this is what I think is really, really important here. So when I received ketamine, I got what's known as the dissociative dose. It was a higher dose. It's an anesthesia dose. The problem is that if you wake up too quickly, you are dissociated. You're hallucinating and you're having a pretty difficult time. And then as that starts to clear, you go down to a partially dissociated dose and then down to a hallucinatory dose, but you can converse. So typically, what we say is in the ICU, we're going to use 0.1 to 0.3 milligrams per kilogram. And it may be that nobody really wants you to be here, right? Because it's an excellent analgesia, but now your patient's kind of high, they're hallucinating, they can converse with you. And as you get higher, they're going to be obtunded and completely removed from all external stimuli. It's mostly on the titration downside of ketamine that it can be a problem. Now, the other thing that we talk about and we're always aware of is sedation withdrawal. And both benzodiazepines and propofol, because they both cause amnesia, they can really create significant long-term problems. But in the period of time where you're administering these agents, you are blocking stage 3 and stage 4 non-REM sleep. Now, that non-REM sleep time is when you are restoring particular actions of your mediators and your proteins. So this is really important and has been the major driving factor behind the consideration of controlling sedation more effectively and look at an anti-anxiety with a new eye. So really, really important to also appreciate that patients in the ICU who've been on benzos or propofol for 4 or 5 days may have significant withdrawal symptomatology. And those clinical features are all of a sudden, they're all agitated. They're having tremors, they have a fever, they're tachycardic, hyperventilating, and combating with our ventilator. So, a word of advice. When we transition from sedation, never go cold turkey. You should wean propofol at a controlled rate. So you're on 75, you should be going down 5 or 10 per 30 minutes in a controlled way. And if your patient becomes agitated while you're trying to transition, you might need to use another agent because every time you go back up on that agent and you wean it down again, they're going to be agitated again. Okay, so that's a really important perspective. The other thing is that if you're using continuous analgesia, that synergistic effect with sedation may also make this situation much worse. Okay, so I already said these things, that's why I move forward. Okay, so 6 final points. Dexmedetomidine is very different from benzos and propofol because those are sedation agents. Dexmedetomidine is an alpha-2 receptor selective agent. So much lower risk for hemodynamic adverse effects, much lower risk for bradycardia, and actually promotes anti-anxiety rather than sleep or what we perceive to be sleep. Point number 2, Precedex is comparable to benzodiazepines, but it behaves very differently. Patients can respond to stimuli, they can cooperate, they can communicate in a much better methodology than patients who are receiving midazolam or propofol. Point 3, less respiratory depression, more respiratory control, lending itself more to awakening and extubation. And really important is that Precedex is much less commonly associated with delirium. So yes, fabulous that we can extubate you sooner, but what happens to you when you leave our ICU or you go back home? You can't balance your checkbook. You can't hold down a job. You think people are trying to kill you. You're angry all the time. You ruined your relationship with your wife and your children, which happens a lot to our critical patients after they leave our ICU. Point 5, cardiovascular events and adverse events with Precedex are the most commonly reported. So we don't see that quite as much with midazolam or propofol, but very important to remember. If the patient is already bradycardic, you're going to be very cautious. You have to have a good discussion about whether or not to use Precedex. If your patient has a second degree heart block, so either Mobitz type 1 or Mobitz type 2, you need to be very cautious about integrating Precedex into their agenda. And you, as the bedside nurse, need to make sure your physicians know that the patient's got a heart block. And remember, it is really meant for hyperadrenergic patients. So really designed for patients who have a normal blood pressure or a little bit of hypertension, a normal heart rate or a little bit of tachycardia or a lot of tachycardia, but you wouldn't want to initiate Precedex on somebody who is hypotensive and bradycardic. And let me say it again. You don't want to initiate Precedex on patients who are hypotensive and or bradycardic. That's going to be your limiting factor. And most importantly, don't expect patients to be knocked out. Dose correctly. Start at 0.2 to 0.4, titrate 0.1 to 0.2 every 20 to 30 minutes, max to 1, never go above 1 without a doctor's order. If you go above 1 without a doctor's order, you are operating outside of your license. So just be sure that your order sets are actually protecting you, and make sure that everybody who is using this doesn't consider it titratable like you might consider Versed. You know, sometimes we go up to 40 of Versed in head injured patients. Can't do that here. Can't go to those higher levels without a particular doctor's order. Now, this is all going to be congruent with the A, B, C, D, E, and F bundle. And you'll see F isn't down here. F is family engagement. So I always think A for assume pain, assess for it, prevent it, manage it. B is that you need to actually put into place spontaneous awakening trials and spontaneous breathing trials. And that should really begin within the first 24 to 48 hours of intubation. You need to be very aware about your choice of and your use of analgesia and sedation. You need to evaluate your patients every shift for delirium. Once you're intubated, you need to be assessed for delirium every single shift. You need to implement an early mobilization strategy. That means moving the patient in the bed and getting the patient up to the side of the bed, even when they're intubated, getting them out of bed. Now, you have to have support for that. You can't just do that. You need everybody to agree. It's a team effort. And families must be involved, and they need to be as involved as we can possibly get them to be. Some families don't want to be very much involved. Other families would like to be able to wipe the face. They want to help bathe the patient. They want to suction out their mouth, not suction in ET2, but the mouth. Many of these things we can train our families to do, facilitate their participation in care. Their presence can be calming to this individual who is under our care. It's a really significant bundle, the ABCDEF bundle. It really facilitates liberation from the ventilator, earlier ICU and hospital discharge, helps patients to retain their normal brain functions and return to a more normal and independent functional status, and improves survival. So this is very similar to what most of our hospitals use. This was what was put forward by the Society of Critical Care Medicine. And it's basically an SAT or sedation assessment screening tool, and actually cutting your sedation to half and then considering turning it off and then adding it back at half if patients fail their sedation training. And then spontaneous breathing trials, always performed by your respiratory therapist, that if patients have had a sedation vacation and they're not on aggressive sedation, they have no agitation, they're well satted, their PEEPs, typically we're going to say a PEEP of less than 8, or an FiO2 of less or FiO2 of less than 50%, don't have any cardiac effects, we're gonna give them a spontaneous breathing trial. And in most cases, actually, we're going to consider early extubation. It's really important to consider the role of the bundle in the real world, right? Because hospital systems are different everywhere. But actually, the most important thing of utilizing the bundle actually helps us in evaluating patients with hypotensive delirium. And that really helps us to organize with our physician colleagues and our pharmacists ways to assist patients with delirium. And by the way, the number one way is not Haldol and all of its children. The number one way to improve delirium is mobilization. To get patients to sit on the side of the bed with their feet on the floor is an amazing event, and oftentimes will take a combative patient into a patient who is calm and cooperative. So really, really important for us to consider when we're actually evaluating our patients and considering what we'd like to see. Now, I'm not sure what time it is. I'm so
Grammarly
excited.
helps you work
Sorry
more
about this.
efficiently,
I hope you can-
which makes accomplishing your work
hopefully
goals
you can see
easier.
that in a minute.
Get full sentence rewrite suggestions so you can say what you mean faster. Use Grammarly to select multiple corrections at once. Instantly accept
I'm
grammar,
on
spelling,
this.
and punctuation suggestions
So I
with a
just want
single
to
click.
share this screen.
Because when you work
And
more
I'm gonna
efficiently,
skip
you
this
have
ad. Sorry about the ad. But this is probably one of the most compelling things I've ever seen. So
For 3 weeks, I was held in a room. If I tried to get away, they would tie me to the bed. I couldn't eat. I could barely sleep, and I couldn't speak. Groups of people would come into the room and look at me and talk about me and sometimes undress me. I was shot full of drugs. I was too weak to move. I couldn't see my body, but I had been cut nearly in half. There was insects on the walls and ceiling. I was in a boat in the bottom of an underground waterway. I was in a deep well. I was tethered to the ground by rubber tubes attached to my genitals. I was in a space pod. I was on a raft, in a library, in a conference room, in a fly-by-night health clinic. I was in the Arctic. I was in the desert. They were trying to kill me. They would try to get me into a room separate from everyone else or wait till late at night. I had found out about their secret pornography ring. I tried to tell my partner about this in hushed tones because I didn't want them to hear me and redouble their efforts. Where was I? They asked me this every day and I didn't know the answer. I was in the intensive care unit, the ICU of one of the best hospitals in the world, where doctors and nurses were using the most current medical technologies and know-how to save my life. A few months later, after I'd gotten home from the hospital, I went to see the surgeon for a checkup. And I told him about these terrible memories and the resulting diagnosis of PTSD. He said, PTS what? People don't generally remember anything from the ICU. Why then was I having nightmares and flashbacks and sleeplessness? Was it because I was weak? Did I lack resilience? Was I too sensitive? Was I crazy? Why was it so hard to do the things in my life that previously had been fairly easy? Why couldn't I seem to move forward? And why wasn't I perfect the way the surgeon said I would be when I recovered physically? What had happened to me in the hospital? They saved my life, and for this, I am deeply grateful. But life after this ICU experience was extraordinarily difficult.
So,
The surgeon said maybe
Sorry
these
about that.
memories had helped me to survive. But the memories weren't of things that had really happened. There was no pornography ring. There was no insects on the walls and ceiling. The staff was trying to save my life, not kill me.
I would tell you that I feel that that is one of the most compelling things I have ever heard when I think about ICU care. And when I think about how hard we work to save our patients' lives, but that what I believe is really important is for us to have a greater level of understanding in this process and to really appreciate that our number one goal is to reduce anxiety, but to promote the calm, cooperative, communicative environment that actually does not just sustain their life in the ICU, but also sustains their life beyond that. As some of you may know, on Monday evening, every Monday evening before COVID, I had a family meeting from 6 to 7 for any family of critically ill patients in the hospital and from any ICU. And the profundity of that relationship with families, and then that sustained relationship where people would call me months after they'd been discharged to say, you know, we're getting a divorce, we can't get over this. My husband always thinks I'm trying to hurt him. My wife thinks that I'm trying to sell her into a sex ring. And of course, I'm not a therapist, but I would recommend them to some therapists who work with PTSD. I think it's a wonderful opportunity for us to appreciate that sedation, awakening, and spontaneous breathing trials are not about just turning off sedation. They are about promoting restoration of mental and physical wellness that goes way beyond the walls of the ICU. I'm so grateful for your time. I thank you so much for being with me, and for many of you being with me every day, every week. I'm so grateful. I'm so grateful for what you do. And I hope, as always, that our time together enriches us, all of us, me too, enriches us in ways in which we look at our critically ill patients and our critically ill families, that promotes better communication between us and our colleagues and our partners. And I want to say thank you, thank you, thank you. I am going now to stop recording, but I'm very happy if there are any questions to answer any questions.